Hello, followers of Neuro Takeaway. Today we have the great pleasure and honor of receiving one of the greatest neurologists in these times, Professor Josep Dalmau. Even though I'm sure most of you have heard of him, I'm gonna read a very brief summary of his long career. Dr. Dalmau received his MD physician doctor from Autonomous University of Barcelona. He trained in neuro-oncology at Memorial Sloan Kettering Cancer Center at New York, and then joined the faculty. After 11 years, he became co-director of neuro-oncology in the University of Arkansas. In 2002, he was named Professor of Neurology at the University of Pennsylvania. Currently, he is ICREA Research Professor in IDIVAP's Clinic Hospital, Associate Professor of Medicine in the University of Barcelona, Adjunct Professor of Neurology in the University of Pennsylvania, and guest researcher in the NIH, US. He's also editor of Neurology, Neuroimmunology, and Neuroinflammation, a member of many academic societies, including the National Academy of Medicine, and he has received numerous awards, including the Jacobi Award, which is one of the most important in our field. And since 2015, he is listed as a highly cited researcher by Clarivate Analytics. So, with this introduction, hello, Giuseppe, how are you doing? And thank you for being here.
Oh, thank you. My pleasure to be here. Thank you for inviting me. Again, it's a pleasure.
How is everything in Barcelona with the quarantine?
Well, now it was a few weeks ago was a little bit better. Now it's still a little bit better, but now we was having some flares around the city again, and so everyone is worried a little bit, but obviously we are not in full confinement as we were for close to 3 months. So actually now I'm in the office here at work. I can be here. Actually, I was quite confined here in my office.
Hopefully you don't go back, because that would be sad. No?
Yes. Oh, yes, definitely. I think that would be bad to go to have again the same experience. But I think that we have to be prepared, because logically it's going to happen, like like flares now and then here and there by local areas. Yes. Sometimes not so local, but I think that this is what's unfortunately is going to happen for a while.
Okay. Well, I have several questions for you. The first question that I have is, after such a successful experience in the US, what made you go back to Spain?
Well, many times people ask me that, and there is no direct, no clear answer, no one reason. Perhaps if I have to summarize very fast, is perhaps that it was in a moment in that I could be in several places, and if coming back to Spain would have represented just this, coming back to Spain without continuing in the US, perhaps I would not have come back. But I have been very fortunate to keep positions in the US and to come here and to go back. And it was also in a moment that after many years in the US and about close to 10 years at Penn, it was a little bit time to change. And actually there were factors leading also in this direction. I just wanted to focus a little bit more doing research than what I had done for many years, which is seeing many patients. So I wanted to put the balance a little bit more also to do research. And then there is a position here in the Catalan government that allowed to have which is a very interesting program, which is ICRIA, which allows me to have this situation, this position. So that's the reason. And the other reasons were also, and these are very, very important, of course, they're also socio-familiar reasons. My parents were getting quite old, and actually my dad had a stroke, and it was time for me to be closer to them. And then another powerful reason, you want to hear the reasons, is that my wife, who is also a neuro-oncologist, Dr. Mirna Rosenfeld, and she's from New York, she fell in love with Barcelona many years ago. So she really was the pusher to come also to Barcelona. So that's an important reason.
Of course, she decided. And do you have the same tools for researching as you had in the US, in Spain?
Yes. I had not missed these tools. No, there are things. That's one of the advantages, that there is no perfect place in the world. Okay, I mean, some things are better here, some things are better there. In terms of the healthcare system, everybody knows that it's the European, not the Spanish only, but the European is better for the patients than, and sometimes for doctors, because you don't have these pressures of insurance companies, this enormous waste of time, sometimes just to trying to convince an insurance company that this patient needs an MRI, for example, right? And in terms that there are also limitations here that, here in Barcelona and in the institution that I am now here, we have all types of platforms to do research. But of course, in some areas in the United States, of course, some things are better, So I'm trying to, I am in a moment in my life that I can tell you a little bit shamelessly that I'm trying to extract the best and from each site and system. No?
Okay. Well, there is a kind of explosion of immunomediated diseases in general, and especially in neurology. Do you think this is due to that there is a real increase of these processes, or there is just that we are recognizing them more nowadays?
I think that is the main reason, is that we are recognizing them more. That's the main reason. And then this has a domino effect. We recognize them more, and therefore they are published, and they are published more, and there are many publications, sometimes of a single case, so that there are many publications like these. Of course, there are also series, but it's a field that has attracted to many people, and therefore there is a lot of excitement and enthusiasm in publishing this. And then there is also, this is the positive part, and then there is also a little bit of a negative part, is that besides detection, it's important to interpret the results. So you can detect things and antibodies, but then you have to put these in the clinical context, which as a clinician, as you know, this is always a major goal in all types of studies.
It's a real challenge, I think. What term do you prefer more, immunomediated encephalitis or encephalopathies? And I tell you why I ask you this, because I am a neuroradiologist, and we are accustomed to link inflammation with gadolinium enhancement. And many of these processes, most of them, I think, doesn't enhance with gadolinium. So I wonder, this is inflammation, this is not inflammation. What can you say about that?
Yeah, well, it's you can have both scenarios. Essentially, I think that in all these types of autoimmune disorders, let's put it in a neutral term, no disorders, not inflammation, or not encephalitis, not encephalopathy. But in most of them, there is a component of inflammation that you can see on the spinal fluid. In many of them, there is definitely there is an inflammatory process going on in the central nervous system, because the spinal fluid reflects this, and sometimes also in some diseases more than others. You have that the MRI is abnormal. Not you're right. Not very frequent with enhancement. Actually, enhancement is usually rarely seen in these diseases. But you have these patterns of suggesting an inflammatory process also. So in some ways, is a mix of both. So you can argue that this is an inflammatory process, so this is encephalitis, but also in some of them, this inflammatory process is probably at minimum, like anti-cyclone 5 disease, in that it's an inflammatory process, but is a chronic process, is a very fascinating disease, very chronic. In some patients, sometimes it's faster, but in most of them it's chronic, and it looks like a degenerative process, right?
This is the one that is associated with the sleep disorders.
Yes. So you have arguments in both sides.
Okay.
Yeah. So in some way, many times we use autoimmune encephalitis for the ones that are obvious, that usually there is a component of inflammation.
Okay.
But yeah.
When we find these antibodies, I wonder, all of them are pathogenic. There is a real proof that they are pathogenic, or they can just be bystanders and epiphenomenon.
Well, for the ones that have been published, most of them, the ones that there are series of patients that there are that are best known, like NMDA or LGI1 or all these types of antibodies against the receptors or proteins, there is clear evidence that these antibodies have a pathogenic effect. And you have in vitro models, you clearly demonstrate this when you put cultures of neurons and you add the antibodies of the patients, of the spinal fluid of the patients there, or when you infuse animals with these antibodies, that they show alterations of behavior, memory, and from one to the other you can see different things happening. So I think that for all these antibodies, that it was initially categorized in a very simplistic manner, antibodies against cell surface proteins. So which means is that if you have live cells in a petri dish, like live neurons, if the antibody is bound on the cell surface and bound to these antigens or receptors, you will find that these antibodies actually have effects that they are different depending on the antigen. For many of the antibodies that preceded these ones for many years, like the ones that we were studying when I was in New York City at Sloan Kettering, in that they are targeting intracellular proteins. Like many of these antibodies are not really pathogenic directly, that as far as we know. And these ones is interesting because they were discovered many years before the current cell surface antibodies, and there are no convincing models suggesting that they are directly pathogenic. And then you can argue also if these antibodies are bystanders, and actually probably not, because let's say you have a paraneoplastic encephalitis with small cell lung cancer, and you have a sensory neuropathy or limbic encephalitis in this term, and you have what's called, what we many years ago called AGU antibodies, you basically don't find these antibodies in other scenarios beyond that. So we don't understand very much how to categorize them, but in some way are linked to the disease. Even if they are not pathogenic, they form part of this disease. And probably it's a disease in that there are the T cells, which are the very bad guys in this disease, and the antibodies form part of the immune response.
Okay. I think that people from your team proved that there are some processes that can trigger an immunomediated encephalitis, and the best known is herpes encephalitis. And I wonder if other processes, maybe more common processes like neurosurgery, or like a traumatic injury, may induce the same process. Is it frequent? Has it been proved? Because theoretically, it's the same mechanism, I guess.
Yes, it has not been proved. Now we have to put in perspective the experience that we have of already many years. So, for example, let's say anti-NMDA receptor encephalitis was reported initially in 2005. We reported this in 4 patients, although at that time we didn't know that the target was the NMDA receptor. This was published in 2007. But so that means that we know, or we start working with this immune response by 2003. It took us at the beginning a lot of time to characterize the disease. Nowadays it takes a few weeks, but at the beginning it took a long time. So, but since then, we have studied hundreds, we have studied thousands of patients, like, I don't know, probably 40,000, because people at the beginning contacted us for any imaginable thing. People thought that this could be immune mediated, whatever you think about it, a stroke or whatever. And you realize over time that you have this enormous amount of patients that can be as controls to answer your question. And it doesn't really happen. So you need really a specific setting for this type of immune response. Or you have a tumor that express these proteins, like an ovarian teratoma, for example, or for other diseases is another type of tumor. And this tumor contains these proteins and expresses these proteins. And it is in some ways an aberrant tissue, is an abnormal tissue that we have and initiates an immune response. This is one way to initiate, to trigger this disease. Another one is, for example, is herpes encephalitis. Herpes encephalitis is very interesting because it's a very potent inflammatory disease with a lot of neuronal destruction and with a lot of release of neuronal proteins, but in a very rich environment of inflammation.
And in the place where there are a lot of NMDA receptors, no, the temporal lobe.
Exactly, and you have a similar scenario with another similar type of encephalitis, which we don't see here. That is Japanese V encephalitis, which is the encephalitis, probably the most common encephalitis in the world, infectious encephalitis or viral encephalitis, which is Japanese V encephalitis. And these patients, they develop exactly the same as the patients that after herpes encephalitis developed NMDA receptor antibodies. They have exactly the same type of curve. You know, they first present Japanese V encephalitis, which is also a very destructive type of inflammatory process with a lot of neuronal protein release. And then the patients, you treat the patients, they get better or not, but then a few weeks later, they come back with the autoimmune encephalitis. And they come even with the same type of syndrome. In some way, it's the same autoimmune process. So yes, so we know about these triggers. Then there is always the question that other viruses can be involved. You can never say never, but actually so far the experience says that it's questionable. There have been 1 or 2 cases of possible varicella zoster, encephalitis, but this is not a consistent number of patients. So this is another trigger. Yes, and then there is some genetic predisposition for some of these diseases, not for others. Not, for example, for IGLUN5 that we mentioned before, this disorder that causes a very characteristic sleep problem. There is a very, very strong association with an HLA type. But for NMDA receptor encephalitis, it's basically, it's very questionable. There are some articles that suggest the weak association, but and so on. You can go with any of these. Now there are going to be soon 18 diseases. You can go through each one, and each one is different in terms of triggers and mechanisms.
There are 18 so far diseases.
Yeah, the ones that are that started since the NMDA receptor antibodies, and until now, until recently there were 16, but now I think that very soon will be 18, because there are a couple more that probably will be reported in a few months that we have been working with.
Getting complicated.
Yeah.
I have a question because, you know, in Argentina, I think in other countries of Latin America, sometimes it's not easy to get the antibodies, especially with the cell-based assay, which is the proper way. Is it possible to diagnose an autoimmune encephalitis without the antibodies? What do you think?
Yeah, I think yes, you can diagnose a disease with or an autoimmune encephalitis without the antibodies. I think so. What happens is that you don't have many times, except with very rare situations, like a typical limbic encephalitis, after excluding many other potential causes of it. And if it follows some criteria, you can diagnose the disease without the antibodies. You can even diagnose with quite accuracy NMDA receptor encephalitis or LGI1 encephalitis. But you basically, at the end, it's nice to get the confirmation of this in case that the patient needs some additional immunotherapy or the patient has a relapse. So it's always better to have this type of confirmation. But in some way, we dedicated a whole entire paper in Lancet Neurology in 2016 with this type of differential diagnosis of the encephalitis and the process of how to do it in order to be close to the diagnosis or make the diagnosis without the antibodies. So this paper is interesting because actually I suggested to my colleague, friend here, Cesc Graus, and I said, Cesc, we had many times the question that you are just asking. In places in that the antibodies, they don't have the antibodies, facilities to study antibodies, or just takes many weeks to get the results. So we should try to write a paper, many basic and clinical aspects, and let's think about it like if we were in an island that we have no way to send samples. So that was the beginning of this paper. And of course, at the end, we always consider, well, we are in an island, it's very difficult to send samples, but after several months, we get the samples back, to confirm these results. So
let's define some criteria.
Exactly.
There is a clinical dilemma, very, very frequent in the acute clinical setting, when one patient comes with an encephalitis and you don't know if it is the viral directs the injuries, the brain, or if it is an immunomediated process. So that has to do with the treatment, because if it is the virus, maybe you don't have to give steroids. And so is there any clue to differentiate this in the acute clinical setting?
Yeah, I think that this is, in most instances, this could be relatively easy. In most instances, always there are some cases that could be complicated. But for the autoimmune encephalitis that are triggered by herpes encephalitis, in most cases, you have like a double curve. Initially the patient presents herpes encephalitis, a viral encephalitis, no? And at that time, it's easy to make the diagnosis, because if the PCR is positive, you have the diagnosis. So you treat the patients with antivirals, and after X time, usually 21 days, if they are children, for example, the treatment is discontinued, and then you test again the spinal fluid to make sure that the PCR is negative. So whatever happens after this time, it should raise the awareness, or be aware that if anything happens, if in a few weeks the patient comes back with something new that sounds like an encephalitis, right? So the first thing to do is to repeat the PCR in case that there has been a reactivation of the virus. But if the virus is not reactivated and the patient has again an autoimmune, an encephalitis, you have to become very, very, very suspicious that this is autoimmune, because you have the previous history of the viral process. You have that at some point the PCR was positive. Now the PCR is negative. And on top of this, the patient presents a clinical picture that has been relatively well described in adults and in children. In children, basically, even clinically, you can make the diagnosis, because if they are very young, they almost always present with what's called chorioatetosis post herpes encephalitis. Mm-hmm. And so this is very easy to spot. It's like if a child comes to you with opsoclanos, you don't have to be a great clinician to see that the patient has opsoclanos. So in some way, that's an easy one. In adults, is in people that are usually young adults or adolescents, it can become a little bit more difficult, because in these patients, the presentation can be more cognitive and psychiatric. And in these ones it's difficult, because in children they have all these abnormal movements. That's very easy to see them. But in patients that are adolescents or adult patients, there is sometimes one possible mistake is consider, well, the patient has all these problems because had the viral encephalitis. So in here you have to be suspicious. And in these ones, the antibodies help very much.
Okay. We are using, I think, all around the world, we are using a lot of immunoglobulin treatment, IV. I think sometimes we are using it too much. That's my opinion. But I'd like to know your opinion about how long should we use this treatment and at what interval, if we have to repeat it, when there is no response to the treatment.
Yes, yes. In here, we have now to center the question in autoimmune encephalitis, because in other diseases, you may need a continuous, periodic administration of IVIG. Now, in the autoimmune encephalitis, there are no clear criteria of rules of how to use the IVIG. We have the tendency to use IVIG very shortly, for a short time. So if the patients come with encephalitis, many times they are already come that they have already been treated, or they have received one dose of IVIG and steroids or plasma change. IVIG is usually more frequently used for practical reasons. These patients can be very agitated sometimes, and the plasma change can be a little bit more difficult, but it can be also used. Anyway, going back to the IVIG, is that if the patients improve dramatically with the medication, then it's continued for a few months, not very much, and for about 3 months, not very much longer than that. In the patient improves very, very fast. But if the patient does not really improve, you don't see any response, we usually move on to another type of treatment, second line of treatment. And many times the second line of treatment, which for us has become basically a first line treatment, is rituximab, which is more expensive, but it's highly effective in these diseases in general. So one way or the other, if the patient does very well, we use short time IVIG. And if the patient does not respond, we don't keep the patient on IVIG. So one way or the other, we don't use it for a long time.
How long do you expect the response after the IVIG?
That's tricky. I mean, it's a tricky question. For some of these diseases, the response, you can see it in a few weeks. For some others, like the NMDA receptor encephalitis, it may take longer than that. Now, how long we wait to see if there is any response in NMDA receptor encephalitis? I think if you don't see that anything in the first 2.5 weeks, 3 weeks, people should move to some other type of strategies. What we do actually is, again, we use upfront rituximab and sometimes IVIG, but upfront we don't do any more this multi-step type of approach and give IVIG and steroids and wait, and if they don't respond, use rituximab, and if this with time has been diluted, and there is more tendency to be more aggressive from the very beginning. You can argue that it's more expensive, yes, but we are learning more also on these patients in the long term, what's happening to these patients, and I think it's worth to be aggressive from the beginning in immunotherapy wise. Many of them are very young people, and you want to make sure that there will be not sequelae and they can recover faster, and they do that if you are more aggressive. This is my experience. So I think it's worth to do it.
Good point. You know, after your discovery of an MDA encephalitis, it was like a revolution in medicine, in neurology. You know that. And there is the question if there are some epilepsies, dementias, psychiatric disorders that could be caused by antibodies. Do you think this is a fact, a myth? What do you think about that?
I think that I think that it's much less of what the literature shows. Okay, I think that is why is a way to publish papers, and it's a way to ask for grants. That sounds very well and nice, many times. So if you take, for example, an NMDA receptor encephalitis, right? That has it. If you see this disease, you can. The best way to see the disease is see the whole entire syndrome and how it evolves in front of you. When you see the whole entire picture, the diagnosis many times is easier. But if you don't put this in perspective, there are many symptoms that these patients develop at different stages. For each one, you can make a topic. Okay, these patients present with they have seizures. So you can put papers on autoimmune epilepsy. The patients have problems, abnormal movements, these kinesias. So you can clone the term autoimmune movement disorders. The patient presents with psychosis. You can clone the term autoimmune psychosis. Yes. And you can make, of all of it, you can make basically, it's like if you have a well-defined disease like Parkinson and now you start developing criteria for tremor, for here, for that, the disease, you have to know the disease. It's better to know the disease than to develop criteria for each one of these syndromes. So, and then I don't think that also this approach is helpful very much, okay? And we showed this actually in the last 3 years. I think that the opinion of many people had changed. The example is, for example, in autoimmune epilepsy, right? Yeah. So there are tons of papers of autoimmune epilepsy until approximately 1.5 years ago, in that the number of papers with this term has changed quite dramatically, because what people used to call autoimmune epilepsy was basically seizures caused by an autoimmune encephalitis, okay? When you treat autoimmune encephalitis, precisely, most patients, they stop developing seizures, and they never fulfill the criteria of epilepsy. Mm-hmm. Okay. So this seems to be just only a matter of words, right? And saying, well, what's the difference to call autoimmune seizures or autoimmune epilepsy? It is a very important difference, because seizures is a symptom of many diseases. You can have, you don't call, for example, or at least it's not very popular, to talk about tumoral epilepsy, okay? Or infectious epilepsy, which herpes encephalitis. So in some way you have to put the same context for autoimmune epilepsy or autoimmune seizures. It turns out that when you look at in critically this way, the autoimmune epilepsy is very is relatively limited to a few cases and a few diseases, not so many. And what I was telling you before is that it's not a matter of words, because according to the, for example, International League Against Epilepsy, epilepsy is a disease that has no cure for it. The term epilepsy, I didn't create that term. The term epilepsy, if you go to the International League Against Epilepsy. Epilepsy can be controlled completely well, but the term is it's not cure. So if somebody tells you are an epileptic, this is in your medical record, and this can have important implications for, in some countries more than in others, for insurance, for so on. So it's very important to clarify this. So all this amount of papers on autoimmune everything, I think that should be put really in context, and we have to be clinicians.
Okay, I understand. I agree with you. What antibodies are you studying now? What are the latest news?
Well, we are always studying NMDA receptor encephalitis, always. From in many different aspects. So at the beginning was in identifying this disease. Later on was in the first series of more patients, characterize the syndrome. Later on in see the effects of the antibodies, later in animal models. And now we are working in many different aspects of this at the same time. One thing that is interesting is that all over these years, and after all these years that when I say I mean the community, the medical community and neurologists and specialists that study these diseases. Sometimes we think that we know a lot about them, but then when you actually see the patients, and we actually follow the patients, not a snapshot day, one single day, and then you write the paper. When you see the patients and you follow the patients during many months, sometimes years, and you do all these studies, you do radiological studies, you do MRIs, you do functional MRI, you do resting state functional MRI, you do advanced EEG, you test the patients neuropsychologically, you study the sleep, you study how they sleep, you study and if they have good sleep or not. When you do this, you realize that there are many things that are coming up that are new, and you had no idea that this was happening. So this is what we are doing now here in a couple of these diseases. We follow the patients in a prospective manner. They come here to Barcelona. They spend a couple of days here for several times per year. And they sleep here in the hospital, and we do recordings, and we have these advanced imaging also. And this is what we're doing. In terms of the lab, we are always working in animal models. And this is also we are doing. We are perfecting some animal models. And then there are a couple of new antibodies that we're working, but I'll tell you the identity in 1 year from now. It's a secret yet.
Okay, I understand. There are many neurological departments that are starting to inaugurate neuroimmunological sections, special sections. Do you think that's worthwhile, or neuroimmunology goes through all the subspecialties, the traditional subspecialties? What do you think about that?
Well, I think that neuroimmunology should go through a general global training, a classical training of neuroimmunology. And by this, I mean patients, the main type of autoimmune neurological disease is multiple sclerosis, and now there is all types of other types of demyelinating diseases like NMO, etc. So the training should be the conventional training in multiple sclerosis, clinically speaking, And if somebody wants to do lab work, then of course you can do lab work in many different things. This depends of your interest. And in this context of general neuroimmunology, if somebody is interested in this new group of diseases like the autoimmune encephalitis that we were talking, then this should be integrated because these are rare diseases. I don't think that you can have a department or a subsection of a department only dedicated to this, you know. And I know that these diseases attract the attention of many young residents and many people. Sometimes they come. This is a very common question. They come and they say, "Well, we are very interested in these diseases that you are studying, but I don't like multiple sclerosis. No, I just only want to study this." And of course, if you are a neurologist in training or you are a young resident in this, you cannot do that. It's like if you are a neuro-oncologist and you say, you know, I just want to study paraneoplastic syndromes. I don't want to deal with brain metastases. Or I mean, I'm sorry, that cannot happen.
Okay. And my last question is, what advice would you give to a young neurologist who wants to get trained in neuroimmunology?
Well, probably follow this idea. You want to be trained in neuroimmunology, so try to go to a good department that has a section on neuroimmunology, and just start there and continue with this interest. Yeah, I know that in some places this can be difficult to find in some cities or in some areas in Spain or in other places. It can be difficult to find a local place that fits these needs of intellectual curiosity and at the same time development in your career of neuroimmunology. But you know, then you have to look to these major tertiary centers that they have these departments, or depends of your interest. Or then you have to go to some place, move to another place, to another country, okay. which is very healthy. I mean, it's very healthy to move and to exchange ideas and ways of doing things. I encourage all my people I encourage all the people here, either doing basic research or even if they are clinicians, to go abroad, to go to other places and to go for some time, to come back.
I heard
don't come back.
When you went to the States for the first time, you were going to be there just 1 year, no?
Yes. I mean, I went there for 1 year. Yes.
And then
I had a grant for 1 year. I had a grant for 1 year, so I went there for 1 year, and then so I liked it, and then
how long did you stay?
I was close to 26 years. So I didn't calculate this very well. So,
well, Giuseppe, I don't want to take more time from your valuable time. I think that, well, thank you very much for this interview. I am sure our audience will be delighted with it. So thank you so much.
Well, thank you, Carlos. It has been a pleasure, and I hope that this helps to someone.